Good afternoon, one and all. On behalf of Dr. Krishna Rao sir, the Senior Director of Maheshwara Medical College, we welcome you all to today's Knowledge Series programs. The topic of today's Knowledge Series program is Past, Present and the Future of Endoscopy. Today we are indeed honored to have as our guest Dr. Manu Tandana sir, who is a distinct gastroenterologist and physician from the Asian Institute of Gastroenterology, Somajiguda. On behalf of the management, the staff and the students, we would like to welcome you to Maheshwara Medical College, sir. Yes. Maheshwara Medical College is a 1200-bedded tertiary care center and teaching hospital with 150 UG students per year and 55 PG students per year. We've got state-of-the-art infrastructure and high-quality tertiary care facilities, fully equipped ICUs with self-sufficient oxygen generators, NABL accredited laboratories including BSL-2 plus molecular labs providing safe and quality patient care. Maheshwara is at a platform much higher than other medical colleges with a name in this rapidly industrializing urban landscape. To carry forward with today's session, we would like to invite to the dais Dr. Krishna Rao sir. Dr. Krishna Rao sir has done his MSc and PhD from Andhra University, Visakhapatnam, and Healthcare Sector Senior Leadership from IIM Bangalore. We'd like to invite to the dais Dr. Manu Tandana sir. We would now like to felicitate our guest who has taken his time to be with us this afternoon. Dr. Manu Tandana is a highly respected senior consultant gastroenterologist at the Asian Institute of Gastroenterology, Somajiguda, Hyderabad, with over 4 decades of extensive clinical and academic expertise. A distinguished alumnus of All India Institute of Medical Sciences, New Delhi, and as a DM in gastroenterology, establishing a strong foundation in advanced digestive care and research. Dr. Tandana is widely recognized for his expertise in the management of acute and chronic pancreatitis, chronic constipation, and a wide spectrum of gastrointestinal disorders. He is highly skilled in diagnostic and therapeutic endoscopic procedures, including colonoscopy, sigmoidoscopy, and capsule endoscopy. His clinical acumen and patient-centric approach have made him a trusted name in the gastroenterology. Dr. Manu Tandana sir is widely regarded as a mentor, teacher, innovator, and pioneer in gastrointestinal endoscopy. Sir has done his MBBS from Kakatiya Medical College, Warangal, and MD General Medicine and DM Gastroenterology from AIIMS, New Delhi. He's got extraordinary academic brilliance and has received an impressive 13 gold medals, including the prestigious Best Resident Medal from AIIMS, New Delhi in the year 1979. He has received many awards, including the ISG J. Mitra Endoscopy Award, ASGE International Service Award, Master of Indian Society of Gastroenterology, Fellowship of Society of Gastrointestinal Endoscopy of India, and Forbes India recognition for the field of visionary expert. I would like to invite our Senior Director to felicitate Dr. Tandana sir. I would like to invite HOD of General Surgery, Dr. Nagraj sir, to felicitate the guest. I would like to invite our Dean sir to felicitate the guest. I would like to invite our medical superintendent, Dr. Adam sir, to felicitate the guest.
Thank you.
I request all of you to please rise for the national song. We would now like to proceed with the traditional lamp lighting. The lighting of the lamp marks the beginning of new ventures and dispels the darkness and illuminates our path of knowledge, wisdom, and hope.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ
I request all the dignitaries from the dais to their seats in the auditorium.
Yeah, please. I'll stay back. Yeah,
Yes. Yes, the slides. I would like to welcome our HOD, Dr. Nagaraj G. Sir, onto the dais. Dr. Nagaraj Sir has done his MBBS from Government Medical College, Bellary, and his MS General Surgery in Government Medical College, Bellary. He's done his MCH Plastic Surgery from Government Medical College, Bangalore. Dr. Nagaraj Sir has worked in various renowned centers as a consultant plastic surgery in our country, such as Apollo Hospitals, Raichur, Sri Lakshmi Super Specialty Hospital, Bangalore, NABH accredited GBH American Hospital, Udaipur, Rajiv Gandhi Cancer Hospital in Delhi, Sunrise Hospital in Cochin, as well as internationally in King Fahd Specialist Hospital in Saudi Arabia. He has performed more than 1,000 cases of liposuction, 200 cases of abdominoplasty, nearly 150 cases of rhinoplasty, more than 5,000 cases of trauma with all forms of reconstruction, including microvascular surgery. He has performed more than 5,000 cases of general plasty under the Arogyashri scheme of Andhra Pradesh. I request Dr. Nagaraj Sir to speak a few words and open today's discussion.
So thank you all. Respected Tandana sir, it's my pleasure to introduce and like to share your experience today with my students also and other dignitaries and my dear students. In your lifetime, you will get a time wherein which you need to choose one friend in your profession. The friend can be a balloon or blade. The situation will come. to choose either a blade or balloon. So I don't want to talk much about the balloon because already Sir Tandana sir has, I just saw the mesmerizing videos he is going to share with us today. As far as the journey with the blade, because I had a wonderful journey with the blade as a surgeon, that too precisely a cosmetic and plastic reconstructive surgeon. I insist all you people, because most of the times in your profession there will be a competition between you will experience that, the competition between the blade and the balloon. So even the competition will be so much so, like the people, like the prediction starts, who is going to conquer whom. That discussion, that debate also will come most of the times. But as a surgeon, I don't want to say which is what, but with my experience as a blade, with the blade, I had a wonderful journey with the blade. Like along with the blade, going into the tissues, feeling the tensile texture and the reconstruction and reforming and developing into the normal situation and all. And not only the feel of the surgery, I had enjoyed all my life. So with that feel, I don't know how that past 20 years has gone just like that, without much awaiting anywhere. And not only that, performing the surgeries, I had very good teachers like Dr. Mukund Reddy from NIMS Hyderabad, and also Dr. Swain. I wanted to share their names because when I used to watch their surgeries performing as a plastic surgeon, really I used to experience the state like a trance. So with that experience I got inspired and I did my work by taking their inspirations into the consideration. But this is and all a past for you, for the students. I still want to tell one thing for you people. For you, you have to have similar experience, not necessarily you just come to our Maheshwara Medical College OPD and see Dr. Surya performing the thyroid surgery. The way he discusses with the PGs, the way he describes the pedicle, so you will really appreciate and you will get inspired from the Maheshwara Medical College itself that you will choose the branch of the blade. So with that, I don't want to take the much time because our dignitary sir has a lot of a grateful experience that will be surely will also inspire you to create a confusion between the blade and balloon. Thank you, sir. Thank you very much.
Thank you, sir, for sharing your views and opening today's interactive session. To set the ball rolling and continue with the same, may I now invite Dr. Manu Tandana, sir, to speak regarding the topic. I would request the speaker to present for about 15 minutes and leave the topic for discussion thereafter. Sure, sir.
They told me it will be more than an hour, so I took a little longer. Thank you, Pujita. That was a exaggerated introduction of mine. Dr. Adam is my junior and he knows that I was a useless student. So he'll tell it to you. Thank you, Dr. Krishna Rao. Thank you, Dr. Nagaraj, Dr. Adam. Sabid brought me here. Last benches, no escaping. He thought I'll escape, Dr. Krishna Rao. So he sent an army man to see that I reach you in time, which Dr. Sabid did. Thank you very much. It's an honor to be here on the stage. I'm going to take a little more time, Pujita, than what you have given. But first, I'd like to ask you students, I'll talk, my voice is good. How many of you are in the final year or above? Means PGs and final year. Even a PG I don't mind. So almost everyone. Okay, the other way around. How many of you are in basic anatomy physiology? No one. That's good. Have you all seen an endoscope so far or heard of it or know what all is available? Yes, no. Yes, you have seen a procedure also. It's a fascinating field. Ask me, I was one of the students when the first endoscopes came to India in GI in 79. And today it's a totally different world. So I'm going to take you through that world of the past, the present, and the future of endoscopy. Is that okay? You are welcome to interrupt any time. Oh, it's already here, huh? Good, good. Just give me a minute, that usual. You can start from here. No, that's the last one, first slide. Ah. Yeah. Can I make it full screen? Oh. Okay. Visible, all of you? You want any lights closed there? You're okay. Students need to participate. This session is for you. It's been 50 years or more since I was someone like you listening to a lecture, but I would like a little more participation from you. Shall we start? Okay. Endoscopy, I told you, is a fascinating subject, and before we'll come to your career prospects at the end of my talk. In endoscopy, long history, last a century and a half ago, Kusumal was the first recorded case where he passed metal tubes using lanterns, and sometimes the electrical bulb had just come at the end and used to see the esophagus. Innumerable number of perforations, innumerable number of deaths. No medical legal those days, got away with it. The modern era of endoscopy started with Schindler in the 30s. Here you see Schindler using that scope. Can I have a pointer? You were having a pointer. You see the endoscope, I'll use the cursor. That's the endoscope. It was a rigid instrument. This is the rigid scope that he used. See the lady, she had to hold the patient in a particular position, only then he could introduce the scope inside the esophagus. The lady was a sister. Subsequently, I think it's very loud. Okay. No. Subsequently, he married the sister because that was the only way he could demonstrate endoscopy all over the world. There was no one else who could assist him, and so the most convenient way was to get married. They did. Hirschowitz is considered by many an American. He is a Jew settled in America, died recently at the age of 95. He is considered by all of us as the father of modern fiber optic endoscopy. And in one of the classic videos which I borrowed from one of the pioneers, this is how they used to do the endoscopy in 1950s. You please see it's a balloon for inflation is no longer, now we have a modern technique processor, but this was the BP balloon which was used. You had no videos, you had to peer through a very small opening to identify the lesions in the stomach. Peter Cotton is a, Dr. Nagaraj, you asked me ERCP, the pioneer of ERCP, and when he started ERCP in the 70s, we will come to that, the scope was so thick and heavy that he had to hang it from the ceiling. There was no way he could hold the scope in his hand at that time. And this is how the pioneers worked. Whereas look at us today, me in an air-conditioned room, big, beautiful video screen, lovely image intensifier, everything easy. The difference between them and now is this. You see the plane and the controls 60 years back. You see the plane and the controls today. I am not doing a good job. The pioneers did a good job because they worked with limited facilities at their disposal and yet produced results. And it is their hard work that has led us to where I'm going to take you today. So, must honor our pioneers, the people who helped us develop the art of endoscopy. When I joined AIMS, cardio was the in-demand specialty. Gastros was just coming up. Endoscopy, we had probably the second year the endoscope came, I joined gastroenterology. But this was basically what was thought of gastroenterologists when I joined. We can only do diagnostic work. We are inaccurate. Basically, we are impotent because we cannot do anything. We can just put the scope inside, get it out, and send it to the surgeon. So, the surgeons tolerated us, they humored us, and we have come a long, long way from that. So, this is how endoscopy started. The endoscope that I first used was about 2 centimeters thin. Today, the scopes that I use are between 6 to 8 millimeters, showing the advance in technology. So coming to the present, that was basically very briefly the past, and we will look into these fields of GI endoscopy where we have advanced rapidly, and you will see the difference. Ordinary scopy, as you know, Dr. Nagaraj, is white light endoscopy. You see the 3 figures. The one on the extreme left, this is what you see on white light, but if we use a specialized type of endoscopy called NBI, advanced, then you pick up there is something suspicious and you target this area and take a biopsy, you get a squamous cell carcinoma. So an early squamous cell picked up only because we use specialized technique to identify that lesion and targeted a biopsy. So specialized look at lumen is become very common, and here you can see in the various aspects, you can even pick up nodules on the tumor showing a neuroendocrine tumor. Neuroendocrine tumors, as the surgeons will tell you, are becoming more and more common because either their incidence is increasing or we are picking them up more rapidly. And then we have the endoscopes which look beyond the mucosa, and you can see wonderfully in the diagrams that I have given. I have compared it with the pathology slides. This is what you see on the endoscope, and this is the pathology of the same thing. So it's optical pathology. A few years later, we may not need a pathologist at all, only for legal purposes. You will get a vision, a picture which is identical to what the pathologist is giving. And here you will get right from normal to dysplasias and malignancies only on endoscopy. And this is a classical example, an Afghan girl, lady who came to us. I will tell you her story a little later also. This on the left you see is a normal squamous mucosa. On the right side you can see dysplastic cells. This was a very early squamous cell carcinoma, and we picked up not in biopsy, not an imaging, just on endoscopy. So this is the advances that we have made. Familiar with H. pylori? Can you see the movement here? Scopes are so good that you can see the spirochete. It's a spiral bacteria moving in the gut mucosa. That is the advance our endoscopy has made today. 100 times magnification routinely, 10 routinely, special zoom scopes they are called. They have 100 times more larger vision than what is already there. And so not only are we showing clear images, we are going deeper and deeper into the mucosa, and this illustrates the various aspects. From 50 microns to 1000 microns, you are able to penetrate with the different technologies that are available to us. And the size of the lesion. When Hirschowitz started his endoscopy, he had a gastro camera that picked up no lesion less than 2 centimeters was ever identified. Today you can see less than 0.5, and with highly specialized imaging, even lesser and below the surface, we can identify lesions. So that has been the dramatic response in diagnostic endoscopy over the last few years. I told you we started with routine scopes in the late 70s in our country, 50s in the world, late 70s in our country. Therapeutic work started later, and I'll come to it right now. Therapeutic appliances, technology has advanced enough to help us do things which the surgeon does. Dr. Nagaraj just told us about the knife and the balloon. Here I am a physician, but using a device like a knife. You saw this. I can go back again and show you. There is a bleeder in the stomach, big ulcer, there is a visible vessel, and I have not sent him to the surgeon. I have used a device called the clip, there are different types, and clipped it. This is identical to what the surgeon does. He underruns it and puts in a suture. Here you have used a mechanical device and closed the gap, patient comfortable, outpatient procedure. So therapeutic advances have changed. This clip is passed through the scope. We have advanced further outside the scope. We have perforations. Procedures have perforations. This is from Paul Fawkins from Amsterdam. There is a perforation in the sigmoid colon. No panic, no worry. He used this device called the over the scope clip, dragged the perforated area inside, raised the clip. This is from our example. In the esophagus there was a perforation. No surgery, no suturing, just got it in, put a clip, patient walked away. We had to tell them that there was a perforation, but there were no issues. So we have moved to advanced therapeutics, advanced diagnostics, and then advanced therapeutics. What has been radical is that we are breaking barriers. This is where I want to tell you, surgeons and physicians, we are taking certain fields that the surgeons used to predominantly take, and does that mean that the surgeon is outdated? No. We are not competitors, we are co-workers, and we have only one aim. Which patient is best suited for any endoscopic procedure, which patient is best suited for surgery. That is the important decision that you and your surgeon will make. Under no circumstances think that you can handle alone. There will be time when you will need your surgical colleague. So this is not the true picture of where we are treating the surgeon today as an endoscopist. We started with the lumen, then the endoscopies became bolder. This started in the first decade of this century. Pankaj is my contemporary from All India Institute. He moved to Texas. In dogs, you heard of achalasia, no, all of you? Yes, no? So achalasia, as you know, the G junction gets tight. Patient is unable to swallow. Heller's myotomy is what the surgeons will do. Very good procedure. Now a procedure called POEM, per oral endoscopic myotomy has been done, and Pankaj, whose photo you see, he has become Americanized, so they call him J, PJ. No one could pronounce Pankaj, so he became J Pashricha. He is Pankaj actually, and he worked it out in a dog. Subsequently, a Japanese genius, Inouye, did the first human case in 2010, and since then, I don't know how many achlasias you get here, but we have the highest incidence of, highest number of poems, maybe about 6,000 now in all our three centers put together. Here you will see, you dig into the submucosa. This is not a perforation. You are voluntarily going into the submucosa, cutting open the muscle fibers and then sealing everything with a clip. So procedures which were done by surgeons are being taken over by physicians. This is what I want to show you. So this is Inouye showing his. In the first case that it took 110 minutes to us. Today he of course is a genius, but our colleagues do it in about 25 minutes. Poem doesn't take more than that. You cut through the muscle, where you are cutting through the muscle, and then you put clips to close the defect. Similarly, tumors which were under the mucosa, were tough to identify and remove. This technique helped us to remove those tumors also. The cartoon tells us what we are doing. We had a tumor in the esophagus under the mucosa, made a hole, there's the big tumor, it was a cyst, and it was dragged out by the, okay. Voice is okay? Okay. And we removed out the tumors. So that was some of the advances in upper GI. This is all today, we have not come to the future yet. Colonoscopy, the incidence of colonic adenomas and carcinomas in India is much lesser than what is in the West. Colonoscopy was a painful procedure, both doctor and the patient, because the experience of someone pushing something from the lower end is not at all justified in many patients. So, better anesthesia technique and better scopes with better visualization have now come, and scopes not only see straight but they also have retroflexion, so they do not miss anything behind the colonic folds. So you see a forward view and you see a rear view, you don't miss any adenomas, because as you all know, adenomas are potential malignancies. And then further plans are on to produce a self-propelled scope, so that neither is a doctor needed nor a technician. The patient inserts it by an AI, it automatically goes in, takes photos up to the CCOM, comes out, which is later analyzed by the doctor. Many different fields, these are all examples of AI assisted and may find a place in the future. So this is the future where you use AI, a scope which is has so much flexibility that there is no pain in the colon, and then you do the colonoscopy. People want to replace colonoscopy with CT and MR, called MR virtual colonoscopy. I personally feel it's a little away yet, because the crucial element of tissue diagnosis is lost. So this is it. Regarding the lower one, we move on to ERCP. You were to ask, any one of you can tell me what ERCP stands for? Yeah, but from students heard that? Sabit told that, I think. So I couldn't see here. So, okay, he told endoscopic retrograde cholangiopancreatography. You go through the oral cavity, reach the duodenum, pass a contrast both in the CBD and in the pancreatic duct. This was the first, since I'm covering the past also. Peter Cotton is one of the pioneers. He showed this, Rabinow showed the first scopy, but the first publication came from McCune, and this is the diagram where he is showing the ducts, the hepatic ducts on ERCP. So ERCP started as a diagnostic technique to visualize the biliary system and the pancreatic system. Sometime later, 5 years after that came in a conference, this picture was showed, and a Swedish surgeon asked, "You are showing us the stones, why don't you remove it?" Because even as a surgeon, exploration of the CBD in that era was not very easy, and then you have to put a T-tube, and the patient was there for 14 14, 15 days in the hospital. So this is what he asked. You have two stones, why don't you just remove it? You are showing it to us, why don't you remove it? That got two geniuses working, one group from Europe and one group from Japan. I'll show you their photos better. This is their publications around the same time. The left two are from Japan, you can see them in their names, and the right two, Claassen and Demling. Demling is no more, Claassen is there. They are the pioneers. At the same time they invented the sphincterotomy. They made a cut and they could get out stones endoscopically. So a major procedure was avoided by the development performed by these geniuses whose photos you see now on the screen. What has it led to? We have a large of experience because we are a center known for biliary and pancreatic work. Most of the large biliary calculi and pancreatic calculi, which is even more difficult, now endoscopy remains the first choice. of treatment. And we have had the experience of publishing huge number of series where we have successfully used endoscopy to clear all the stones. And this is an example of a biliary stone, huge stone, blasted by extracorporeal shock wave. We know this showing that. Blasted into piece, and then in the next setting I remove all these pieces out. You could not remove this stone because it is too big and the end is narrow. These pieces are easily removed. You see the next one in pancreas, big stone, pulverized into powder, easily removed. The stone totally disappears. So a major obstructive pathology, cause of pain and untold suffering, totally got rid of by a day's procedure. Even further, stones which got stuck or there was difficulty in diagnosis, this spy scope, as the name suggests, the spy scope. Mind you, our common bile duct is 6 millimeters or less in normal, 4 or 5, it's dilated above 6. So people with minimal dilatation, this instrument can be passed in and it can be used. This was a stone which was stuck there. A laser is being used. You can see the shine of the laser. And we are blasting this calculus into small pieces that we can extract immediately. So this is where, as I told you, we are breaking barriers. The other major gains that therapeutic scopes made was the development of these metal stents. Palliation, by the time, I don't know what is the status here to us, all the biliary malignancies come very, very late. CAGB, cholangiocarcinoma, invariably late, and palliation is the best you can offer. These stents help in bypassing the obstruction. Stents are only meant like a cardiac stent. You bypass the obstruction, life is good, you don't cure the patient. And now we are getting radioactive and drug-eluting stents. We are still waiting their final report. So not only will the drugs have metal, and they will be coated with either radioactive substance or chemotherapeutic drugs so that locally they can burn the tumor to the best of their ability. So this was the advance that we made in the 2000s, 1990s to the early 2000s. Small bowel, 22 feet small and large bowel 6 feet, 15 feet of small bowel was considered the final frontier for all luminal endoscopists. The scopes are, today the gastroscopes are 110 and 120 centimeters. The intestine is 16 feet long, 14 to 16. How do we visualize it? Two important innovations in the beginning of this century. The first one by Dr. Paul Swain, which is a capsule endoscope, takes 60,000 photos. You see, comparing it with ordinary tablets there, and it's not moving. Anyway, it goes inside the intestine and visualizes the entire bowel. Yes, 60,000 photos which are gone onto a screen. Israeli technology is the best, and then you visualize that, sit down in the comfort of your room, see and identify the lesions. A classical example I am showing, this is Paul Swain, and I'll show him a little later. This was a young man who came to us with a bleed. Upper endoscopy, colonoscopy, even an utter routine push enteroscopy was normal. We used the capsule. Big tumor, bleeding. Straight away went to the surgeon, lymphoma with surface ulceration. Resected that part of the bowel, he became all right. So not only we identified the lesion, got it treated in one single sitting, because we were able to visualize the entire small bowel. But there is one negative point for capsules. It has no therapeutic ability. Efforts now are on to see a capsule which we can steer, which can have robots with AI and do the work that it is meant to do, not only just take a picture. Suppose there is a small tumor and you want to biopsy or excise it, it should be able to do that. So Paul Swain, again the same man, genius. See, he's lying down, he is fully conscious. He is using a magnetized capsule to see if he can manipulate it. This is how professional geniuses work. They sacrifice their own self. She is showing him, he is watching it on the screen, he is using the magnet on his tummy to see if we can control the movements, because the next aim of capsule is to make a therapeutic capsule which will do not only visualize but do the work. And these are the potential things that he is visualizing. It's not come yet. I personally feel maybe not in the next 10 years also. Everything, with arms to pick up a foreign body, to do a biopsy, so everything, and then to reach, that I'll show you in a subsequent video. So we needed something to reach and do the work in the small intestines. Even the surgeons don't like to explore, exploratory lap and search a bleeding point. So the enteroscopic era began. Three geniuses again, Yamamoto from Japan. Don't worry about the instrument, double balloon, single balloon and a spiral. They devised a mechanism by which a scope of 2.5 meters could pleat the entire small intestine over it. Because balloons anchored, you will not understand, don't get worried. But put it in one word, small scope, they identified the entire small bowel. And you see these next diagrams. Now here you are deep in the intestine. The first one is a telangiectasia, which is bleeding. You use what is called an argon plasma coagulation and coagulate. The second one is a big polyp. You put a snare and do a polypectomy. Third, there are small ulcers because of NSAID. Same APC you use and burn it. And this is a Deulefoy's lesion, we clip it. So not only did you diagnose, you even cured the patient. So this was the next major step. Subsequently, we moved beyond the scope, beyond the lumen. Earlier, when we were students, perforation was considered the biggest crime. Still a crime today, but here our endoscope is purposefully making a hole in the stomach, as G.V. Rao from our institute first did. He went through and did an appendectomy, the first time in the world, and it was, I think, in 2006 that we presented it for the first time. Similarly, gallbladders have been removed. How often do you get pancreatitis here? And is alcohol the commonest cause? Alcohol, stones. So biliary pancreatitis, sir says, is common. We have a combination of both alcohol and biliary, and as you all know, pancreatic walled-off necrosis is a very bad aspect, and surgeons also don't like to open. Earlier we used to do the pancreatic lavage. Today, with the development of numerous of these luminal stents, which are called LAMPs, lumen opposing stents, we are able to drain pancreatic fluid collections without surgery using an endosonoscope. Have you seen an endosonoscope? Yes, no, I want an answer, unless people behind are sleeping. No, yes, no. No, anyway, endosono is an ultrasound attached to the tip of the endoscope, and there you reach closest to the pancreas. You've just got a layer of the stomach separating you with the pancreas. The vision is the best. So we use that device and do this. We are moving further, as this cartoon will show. Please watch carefully. This is a man with gallstones who is unfit for surgery for various reasons. You go with an endosono. This is an endosonoscope. You go in, you dilate the path. This is the stent and self-expanding stent which you see here. You place it in position, you come out and tilt the patient, and the stones come out into the stomach. So this will be the next big thing, where you will do gallbladder stone removal in unfished patients with cholecystitis. So endoscopists are going any place where there is a lumen and a hole. This, I think, exemplifies it. If you have a hole and a lumen, the endoscopist will somehow reach there. So this is about showing it and how we have changed. We started, as I told you, with diagnostics, came to very little therapeutics, and after the beginning of this century, everything is therapy. Diagnostic endoscopy is minimized. Majority is the work done by therapy. And now coming to the Afghan girl that I told you about, 1970, suppose she would have come, the case would have been advanced. Today we picked it up very early. If we picked it up here and took a biopsy 8 days later, the report would have come as malignancy. Today on the endocyto, we identified the malignancy on the same day, the same sitting. Then you did a CT screening to see whether it has spread to the lymph nodes in the esophagus. Today we do an endosono, no lymph nodes were involved. Those days you ask the surgical team to take over and do a radical procedure. Today with endoscopy, submucosal dissection, and the tumor is out. This lady we remember because she came just before the second Taliban issue came, got cured. She occasionally sends us notes, totally all right. Early esophageal cancer, sent back within 4 days from Kabul. Imagine travel was very difficult. Two brief questions: bariatric endoscopy, metabolic endoscopy. In the next few years, probably some of you who will become gastroenterologists will do that. We are using balloons. Now, Dr. Nagris has mentioned balloons to reduce the capacity and use them, but more advancement, similar to what the surgeon does. Can you see this? The surgeon does a sleeve gastrectomy. A physician does with the suturing device sleeve gastroplasty. The result is the same. So you have got devices, suturing devices by which you reduce the volume of the stomach and produce good results. Well, I don't know how many of you know that the focus of diabetes has now moved from the pancreas to the duodenal mucosa. Knew that? You know, GLP-1, GLP-2 are coming, but incretins, anti-incretins? Yes, no? Yes, but the faculty is telling that. So, students, anyway, just for one word, the focus is shifted from the duodenum, from the pancreas to the duodenum. Insulin resistance, type 2, we are the diabetic capital. And how do we get burn? What do? We burn that mucosa of the duodenum. And the new mucosa which comes does not have insulin resistance. That is the wonder. And this is a device. Bayram is from Mayo Clinic, the famous Mayo Clinic. He's, we are professors in Mayo and he's a professor in AIT because we have a collaboration. You use this device, burn it continuously beyond the papilla for 15 centimeters beyond the papilla. The entire cells get apoptic, they destroy themselves, and the new cells that come are devoid of insulin resistance, so you're curing diabetes. So some of my colleagues who are over enthusiastic say the management of diabetes will move over to the endoscopist in the next decade. I have my own doubts, but anyway, we have to keep that in mind. The other way to bypass the duodenum is to put this sleeve. Fix a metal sleeve with a plastic liner for 60 centimeters. The food will go through but not come in contact with the duodenum. So the incretins and the anti-incretins don't come into action, and we have shown results that both HbA1c and overall sugars improve dramatically. What about the future? Robotics has to come. Endoscopic robotics, we did the first cases in the world. This was with many years back with Singapore. Then many things happened. COVID was the biggest thing and we stopped development. Now I don't know, money is short, but we will probably develop it. These are the first 3 cases reported in world literature where we use a robotic arm in the endoscope to remove polyps from the, there you can see in the stomach and colon. And because of that, the big Dr. Rob House is a very well-known endoscopist from US. He said it's a small case series, we only had 3, but he said it's a giant step for endoscopy, what Neil Armstrong said. So number of devices have come, help us in cutting and illuminating. For students like you, we have moved over to the simulators, where you learn real, just like a pilot learns difficult landings and takeoffs on a simulator, you do identically. You familiarize yourself on these machines and then come to the human being. Similarly, animal labs first. This is not the future, this is now. And the future, Yes, many endomicroscope, endocytoscope, molecular imaging, molecular pathology, no longer pathology. And this is a very nice example. Hardikar was a scientist from Pune. He showed us with an endoscope, we injected stem cells at the G junction. People with GERD who have a who have a patent G junction and reflux, these stellate cells subsequently over 14 days accumulated round, tightened the G junction and reduced reflux. So endoscopical injection of stellate cells at the site. Fistulas, I don't know surgeons, this must be one of the toughest things we do. Chronic fistulas, and we have come up with a thing called regenerative medicine, and I'll show you in the next diagram. This is a fistula in the esophagus. Our team is drawing fat cells from the thigh, centrifuging it, and the middle layer is used to inject it submucosally, and you see the report. Fistula disappeared, fistula disappeared. So this, mind you, the surgeon wouldn't like to take it off his own. This is tougher. So these are examples of how we are going to progress in the next couple of years. Similarly, rectovaginal fistula, one of the toughest problems we, and I'm sure the surgeon and gynecologist face. Regenerative medicine, 3 phases, big, small, totally disappeared after 3 months of therapy. What is there in the future? We are planning to inject vectors into tumors which will destroy tumors. This is the next big step. No future can be complete without artificial intelligence. So man and machine have to work together. And again, this is the list. We are not going into it. This is a talk of an hour in itself. All fields of gastroenterology, we are beginning to use AI. The one where we have used it is the colonoscopy, and I'll show you in this classical example. This is Dr. Not coming. Yes. You see, the machine is called the endobrain. You put it on the tumor. What is the person on the polyp? 87 probability of neoplastic tissue. You put it 55%. So the machine, we are using this regularly in our lab. If you have a doubt whether it is a hyperplastic or a neoplastic tissue, use endobrain in the colonoscope, you will get the answer. What about the future? Newer development. I told you endosono was very important. We want to make an instrument where you don't have to change the instrument. Here you have to do endosono once, remove the instrument, do an ERCP. Want to combine both so that in one shot you can finish. So the future is bright. For some of you who will become gastroenterologists a decade from now, probably this will be the in thing. And as big people before us have said, don't think too much about the future, it is going to come soon. Eventually it is science, what you think is fiction. And I end with 2 videos which I feel will be the future for you all. This lady went to AI, had pain, she identified it, AI identified as bile. She swallows a special capsule in the supermarket, medical supermarket. Capsule goes in, the robo opens it, goes in, that's the stone troubling her, producing pancreatitis, and he drags it out. So this is going to be the future of endoscopy. And the other one, this lady gets up in the night, pain and feeling uneasy. She takes a diagnostic capsule which she has, swallows it. The message is relayed to the duty doctor resident. He is watching a football match between Germany and Italy. The moment he sees, his eyes open up because the capsule has gone in and shown a very big bleeder. Now he doesn't want to miss the match, it's the World Cup final. So he activates the robo inside, comes out with a clip, holds the bleeding, happy, patient is comfortable, and he has just seen the winning goal. Italy has scored. So this is going to be the future of GI endoscopy, in my knowledge, 20 years from now, the way AI is going. Thank you very much. If I took time, you'll have to forgive me. Our 3 hospitals, Where I work, the oldest, I'm an old man and least intelligent. The newer people have moved here and now to Banjara. Actually, Banjara and this are the same unit. We are a kilometer from each other. This has just started. These two are now established. Thank you very much for your hearing. One question, if you have the lights, I'll ask the students. How many of you planning to do PGs? What? Slept? Got up? How many planning to do PGs? Anyone planning gastro? Too early. Well, no advice. I'm not forcing you into gastro. Just one word when you choose your final destination, whichever field it is. It could be a plastic surgeon, it could be anesthesia, it could be gastroenterology, it could be community medicine. You are going to spend the next 40 years of your life in that very field till you retire. Choose a field which captivates you, because I am 72 and I can still work because I am interested in gastroenterology. If I lose interest, next day I become old. So do whatever you want. My advice to you is choose a field which you know that you are going to marriage. 40 years you have to live with that. And as long as you enjoy working in that field, you will never feel tired. That, take it from me, pure experience. You know, I was like you in 72. Imagine now, we are 50 plus years. Thank you very much.
Thank you, sir, for sharing your thoughts and ideas. After such a lively discussion on an important issue, we request all students and faculty to clarify any lingering thoughts or doubts.
First, did you follow or did you not follow? I'll go there.
Yes.
You know, ideal time to sleep, closed lights, air conditioned, lunch is there. I may have done that. Adam says he saw me sleeping also in the class. Okay. Okay. Yeah, so there was a question, yes. Well, if you are loud enough, I can hear you.
Sir, what are the important aspects of patient counseling before upper GI endoscopy? Like, how do you address the patient anxiety and discomfort and improve acceptance for the procedure?
Okay.
Also, sir, what skills should future doctors develop to adapt regarding the recent advancements in endoscopy?
First question first. Today we sedate the patient, especially after COVID. Guidelines were passed because COVID, you know, the mortality and coughing was the commonest. Doctors lost their lives. My own colleagues, couple of years junior, I've lost 3 of them because they did procedure on COVID, got COVID. Today we sedate the patient, it's explained, and a legal consent form is given. The chances of a complication in diagnostic endoscopy is less than 1%. You cannot take that chance for legal purposes. There is a prefixed form that we take for legal purposes. The patient is apprehensive, we tell them we will give propofol, anesthetist is here, in 10 minutes the patient is up. And I am sure the best way to do is a center like ours where there is a turnover. If he sits outside in the hall, he'll see in the 10 minutes he is waiting to come to my room. 4 patients would have come out after endoscopy happily smiling. So showing him a known case, convincing him that it is under sedation, and legally protecting yourself by a adequate consent form should be your basic steps. Your second, well, you have to learn the basics first. I cannot do ERCP without learning basic endoscopy. I'll tell you the learning curve is 5 years to come to advanced procedures. So you must have patience and you must have love for the procedure. You're just doing it because someone asked you to become a gastroenterologist is not going to help you. So have love, stick to the job, have patience. You'll learn
Thank you,
everything.
sir. Thank you, sir.
Anyone else? Pujita, you ask. Yeah, can you speak or you want the mic? Which year are you?
Sir, I'm Vamshika. I'm a third year medical student. So my doubt is, are there any situations where imaging is preferred over endoscopy?
Yes, many. Pancreatic first. Pancreatic fluid collections, imaging first. Then an endosono to see if you can drain. Esophageal lesions, you have picked up a small lesion. The endosono will show you small lymph nodes, yes or no. But anything beyond the lumen 2 centimeters, you need imaging. So they are both complementary. Please, not competitive. Very few things in medicine, we make it competitive by our egos. Surgeons and we are complementary to each other. So imaging is complementary to endoscopy. And there are many places where you do endo and then do an imaging, or do an imaging and follow it up with a endo. Okay?
Thank you, sir.
Yes. First, did you all follow? That question was not answered. Followed, slept, what? What did you learn in endoscopy?
Sir, this is Sarini from third year MBBS.
Means pathology, physiology, or clinical medicine?
Community.
You know, we had.
Yes. Community medicine and
Yeah,
forensics.
okay.
Yes.
For us, it was different.
So, what's the most challenging What's the most challenging endoscopy you have ever encountered, sir?
That's a tough one. Challenging, no. You must learn from your mistakes. I'll tell you one mistake you saw an esophageal cancer here, it is early. There was an 88-year-old lady with esophageal cancer. Those days it was advanced, as expected. We never pick up early because patients come late, and she was before this ESD time. So she came, we did, one of the residents would have done, whatever it is, maybe I only did. The biopsy was inconclusive. Now for radiotherapy to be given, they need histological proof. Otherwise legally they are not, neither chemo or radio can be given. Now this lady's relatives were reluctant because she is 88, dysphagia, big growth. But the surgeon, the radiotherapist convinced her, yes, you do no, we'll cure her. Okay, I got the buck, I am supposed to do. There was a big growth. There was a small nodule on the growth. I said, if I pick out the nodule, I will get the whole, chunk of tissue, and there will be no doubt in diagnosis. When I picked out the nodule, that was a aortotumor fistula. That was an aneurysm, and she bled massively. I must have used all my skills, all the clips, all the APCs. 6 hours later she died. From that day, if I have to take a biopsy of a nodule, I first feel it with a scope. If it's a blood vessel, it will go in. Pillow sign we call it, goes in. And if it's solid tissue, it will not go in. All my residents, I tell them, learn. And this I must have done maybe 20 years back. So it was not that I was a new endoscopist. So not challenging, but mistakes. And mistakes which you didn't want. No one expected that to be a fistula of all the things. And it was communicating directly to the aorta, esophagus, somewhere here. So the pumping was like, the whole esophagus in 30 seconds was filled with blood. We cleaned, we wiped, we gave blood. Each time the pressure rose up, the bleeding started again. When the pressure dropped, it stopped. 6 hours later, she was dead.
Thank you, sir.
So that's just, I am not saying difficult, there have been many difficult ones, but this is a mistake which I often tell the students. Never be afraid to accept your mistakes, okay? It's a part of learning, because since then, not only me, all the students who I have taught, about 1,000, have learned this. That if you have a doubtful swelling, do the pillow sign. Take a biopsy forceps, don't open it, just keep And if it's a pillow coming back, it's blood vessel. Okay, anyone else? Yes, doctor. You don't need, I have to,
no, sir.
I have to ask
I'm-
questions.
On behalf of my students, sir, do you have any video wherein which they have little bit imagination problem while like imagining themselves how the scope will enter the sphincter of body? So
Okay.
if you can show that
Scope
one
means
video.
the cannula.
Yeah, please, sir.
Okay, I should be having. My back is there, huh? In that video there will be, I have 100 PGI cast, South Korea, strictures and stones. Yeah, I have a small under this one. Well, anyone asked, it'll take me a little time to search. Here, CBD stone, let's see. Jakarta stock is there. There are different times of the just put it on this. I'm not able to move it. Yeah, in this I'll be able. Just give me a minute. Okay, let's start this. Okay, this was a talk in Jakarta some time back, but we'll move to it. Just showing how a sphincterotomy is being done, because I think that's the basic procedure. Can one of you come here and help me? I'm not able to move this. Full screen. This one, just press this. What happened? Why is this? There's a sphincterotomy there. If it doesn't come, I'm sorry. It's come. Can you go to the next? Yeah, next. That's the sphincterotome going into the papilla, and we are making a cut, and there is the bile coming out. Now you can see. So when you go in, you have the bile duct which goes straight up from your and the pancreatic duct which goes horizontal. Please remember, if some of you have not read it, post ERCP pancreatitis is one of the worst complications we have in ERCP. So you must be well aware of the anatomy and the duct you are going. And if we show more, we may get there. Again going inside duct. Now you can see. And we are passing a balloon to remove the stones there. So as Dr. Nagaraj said, this is how we enter the bile duct, and sometime later I'll show you the pancreatic duct, maybe not now. Okay. I think we can open the lights.
Thank you, sir, for answering our questions. We express our gratitude to Dr. Manu Tandon, sir, for their insightful contribution. I request all of you to stand up for a minute for a standing ovation for Dr. Tandon, sir.
Thank you. Thank you. Thank you.
We would also like to thank Dr. Nagaraj sir and Dr. Krishna Rao sir for their time. I thank you all professors, assistants, associate professors, senior residents, PGs, and UG students. I request all of you to stand up for the national anthem.
जन
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you.